formal good evening, everyone. A
Mhm.
really warm welcome to you, Sanjay, for having taken time off to be with us here today. And for us, he's someone very special. He's the son of our esteemed chairperson, Jyotsna Govil, who's right here. So I think we need to really give you a warm, thunderous applause for having taken time off to be with us in spending this afternoon with us. It's quite a bit. Thank you ever so much, Sanjay. Thank you so
Thank you.
much. And we are all going to be gaining a hell of a lot of knowledge at the end of it. At least we'd be a little wiser than what we are. Because what we hear are only things like pancreatic cancer, we hear about the liver cancer and the transplants, but somehow this bile ducts, we've never gone down that route. We've never
Yeah.
seen it. We may have heard of it, but never understood everything about it. So these are the three that we are going to be doing today: the liver, the bile ducts, and the pancreas. So it's my humble duty, should I say, or my good luck to be able to give a little resume of the amount of work that Sanjay has been doing. And we'll start with sort of welcoming him here that yes, he is a renowned liver transplant surgeon in India and an expert GI and hepatopancreatic biliary. In short, it's HBP. It's quite a mouthful to repeat again
It
and
is a
again.
mouthful,
So
yes.
I'll just say HBP oncologist with 35 years of experience. He is well known for providing patients with compassionate treatment and the superior medical knowledge having been associated with the various reputed hospitals. That I can vouch for because his mother is exactly that, and he's taking on that traits itself. And he's currently working as a senior consultant and head of department of the HBP surgery and liver transplantation at Apollo Hospitals Bangalore after having held various positions at renowned hospitals in Chennai and Bangalore. Actually, the resume is very long. So I've just
No,
briefed
just
it up for
yeah, that's
everyone
enough.
to understand how important he actually is. He has an impressive academic background, having completed MBBS from CMC, that's the Christian Medical Colleges, Vellore in 1985, and having done his MS in surgery, in general surgery from the CMC, he went on to become an FRCS, that's the Fellow of the Royal College of Surgeons of England. Dr. Sanjay also has a Lister Fellowship in Pancreatic Surgery from Glasgow Royal Infirmary. He received specialized training in liver surgery and transplantation from prestigious institutions such as King's College Hospital in London, Queen Mary's Hospital in Hong Kong, and the Graduate School of Medicine in Tokyo in 2004. So, Sanjay, are you going to be planning to do something from the States also?
No,
Because I
no,
see you haven't crossed the Atlantic as yet.
no,
So
just been
maybe
there
that
for
will be
holiday.
something.
Just for holiday.
Okay.
Yeah.
Yeah, that I know. So maybe that will come in future. Now, the honors and awards are also a whole lot of it. He has many awards to his credit, like presently he's the president of the IHBPA, the International Hepatopancreatic Biliary Association. He has had the distinction of conducting many first of the kind transplants surgery within the country. And his area of expertise is, of course, the hepatocellular carcinoma. Hepatocellular carcinoma or liver cancer occurs when a tumor grows on the liver. And the Hiller cholangiocarcinoma is a type of bile duct cancer that occurs in the bile ducts that lead out of the cancer or the hepatic ducts and join with the gallbladder. With this impressive background, we now need to sit back and gain an insight into his learning. I now hand you over to Aruna Umar, who will carry on the format of today's talk. And as she's going to tell you, this is
Thank you, Ren.
first part
Thank you.
of our series. So, Aruna, the floor is all yours.
Thank you. Welcome, Dr. Sanjay.
Thank
Friends,
you.
I may inform you that today he'll be speaking on 3 cancers, as Mrs. Prasad told us. So after each cancer, there will be a very short duration, for a short duration of time, we'll be asking him questions. And so that, because at that time, the information we have gathered is still fresh in our minds. So then he'll pick up the second one and the third one, so on. So you may write your questions in the WhatsApp. I don't know whether we'll be able to take all of them. If time permits, yes, we will. Otherwise, we'll consolidate all the questions, send it to him, send them to him, and then, we'll send the answers via email later on. So, as I mentioned, that we are very excited. These cancers have never been, addressed earlier. So on to you. Your floor is yours, Dr. Sanjay now.
Thank you very much. So I'll just share my screen so that you can see my slides as well. I've just made a short slide presentation to help. Just 1 second. Okay. So first of all, thank you very much to the Indian Cancer Society for giving me the opportunity to speak here this afternoon. It's lovely to see so many familiar faces on my screen, on the Zoom screen. I think if Kangana Ranaut was one of them, she would have said I'm the classic Nepo baby. Since my mother has been with you all for so many years. But yes, I'm very grateful for this opportunity. So I'll be splitting the GI cancers into 2 sessions. The liver, biliary, and pancreatic cancers are what I deal with almost every day and have been dealing with for a number of years. And the second lot, which is the esophagus, stomach, and colorectum, I'll deal with subsequently with another talk. So I'll start with the liver, just to give you an overview of what we're talking about today. So obviously you can see that this big brown thing here is the liver. I'm sure you all know this anatomy. And the green is the biliary tract and the gallbladder. And then the yellow is the pancreas. So just since there was some, you're not aware about biliary tract cancers all that much, I just wanted to say that the biliary tract cancers are actually split into those which occur within the liver, the ones which occur at the hilum of the liver, which is what you were talking about, the hilar cholangiocarcinomas, and then the distal cholangiocarcinomas, which are lower down. So they have fairly similar risk factors and all that with the liver. So I'm going to be largely clubbing them together. I'll speak about gallbladder cancer as a separate. It's put down as usually sort of clumped with biliary cancers, but I'll speak about it separately because it is just so very common in our country. In fact, North India is one of the places in the world with probably now the highest or the second highest incidence, prevalence of gallbladder cancer in the world. So I'm going to start with the liver cancers. So just to give you a preview of the whole thing, there are 2 groups of liver cancer. You have what's called the primary liver cancer, which are cancers which arise within the liver. And then you have secondary or metastatic liver cancers, which are cancers which arise elsewhere in another organ, but spread to the liver. Now, actually, it's secondary liver cancers are much more common if you look across the board than primary liver cancers, because obviously there's so many other organs from which the tumors spread to the liver. And the way we make this out is that these livers are usually normal, healthy livers. As you can see here, nice, smooth, brown, sort of dark brown color, and nice and shiny. And you'll have multiple tumors, usually, not always, but usually there will be multiple tumors all across in different parts of the liver. And this is characteristic of a secondary liver cancer. And the common sites where they come from are from organs within the abdomen. The colon and rectum are very common, so is pancreas, stomach. And the colon and rectum are particularly important because it's one of the few metastatic liver cancers which is potentially curable if the patient gets the right treatment. So it's important to identify these. And you also get spread from the breast, the lungs, the thyroid, various other organs as well. So obviously the risk factors for this, I'm not going to go into in much more detail, because the risk factors for metastatic breast cancer or metastatic liver cancer or secondary liver cancer are the risk factors of the organ from which the tumor starts. So it's really got nothing to do with the liver as such, except that the reason why it tends to spread there is that the liver has got a very fine microcirculation and and a high blood flow, and these as the blood carries the metastatic cells, the tumor cells, they tend to get trapped in the small blood vessels of the liver and grow there. So we'll be focusing mainly on primary liver cancer. And the characteristic features of primary liver cancer are that it's usually solitary and often fairly large by the time it's diagnosed, because God's given us a lot more liver than we need. And by the time patients develop symptoms from their tumor, a huge part of the liver has to have been involved, or the tumor has to be really large. So very often patients come with tumors which are 10, 15, 20 centimeters in diameter, huge, big, massive tumors. Some of them burst and rupture, and that's how they get diagnosed. And the other thing that is very important here is that it's much more likely that the background liver, rather than being normal as it is in the metastatic cancers, in the primary liver cancer, it's usually an unhealthy background liver. Most commonly, it is a cirrhotic liver, and I'll talk about cirrhosis a little bit more, but a cirrhotic liver, or it may be a very fatty liver. Those are the two common causes for diseased background liver, or it may have been infected by hepatitis. So there are two, if you look at the liver is made up of two groups of cells predominantly. One is the hepatocytes, which are the liver cells, and the other is the cholangiocytes, which are the bile duct cells, and it's the bile ducts which carry obviously the bile which is produced in the liver cells down into the GI tract. So if the tumor arises from the liver cell, it's called a hepatocellular carcinoma, or most people know it as HCC. And if the tumor arises from the bile duct cell, it's called a cholangiocellular carcinoma, or CCC, and many people call it an intrahepatic cholangiocarcinoma, or so you may also find the term IHC being used for these tumors. Okay, so it's not that the background liver is always diseased, but it is diseased in about 70 to 80% of patients. 20 to 30% of patients can develop these tumors on a background completely healthy liver. So broadly, we're looking at a primary liver cancer and a secondary liver cancer, and the primary liver cancer is broadly of two types. Okay. Now, if you look at the risk factors, so we'll just, I'm sure I haven't made very fancy slides, they're very basic, but just to go through what are the underlying problems. So as I told you, usually the HCC, you get an underlying liver disease, which is responsible for the tumor developing. And the most common cause is cirrhosis of the liver. Now, cirrhosis of the liver is a progressive disease of the liver, in which it starts off being relatively uninvolved, and then it gradually turns into this really shrunken nodular kind of liver. So if you imagine that in the beginning the liver is something like a sponge, and then if you grab the sponge and you squeeze it with your hand and you have little bits of the sponge protruding between your finger, that's what cirrhosis ultimately looks like. It's a small liver, it's hard like a stone, and it's nodular. It's like a whole lot of little bumps. And the reason it forms these bumps is that the liver, from a variety of reasons, starts getting scarring within it. And the scar tissue acts like a shoelace, if you like, or a spring, and it pulls the scar tissue, pulls the liver tissue and the capsule of the liver, the covering of the liver, into the liver itself. You also may have heard that the liver is one of those organs which can regenerate. And you know that this whole, coming in Delhi, you've all heard about living donor liver transplant and how the liver grows back in the donor. So when the liver gets damaged, it tries to regenerate. And these nodules that you see on the surface of the liver are bits of liver which are trying to regenerate. And the area around the nodules are the scars which are squeezing the liver and making it smaller. So that is a typical thing of cirrhosis. There are a whole lot of different causes of cirrhosis, but the common ones you all know. I mean, alcohol, of course, is the, in the public perception, is the number one cause, and it still remains that. But the other is non-alcoholic steatohepatitis, which some people know as non-alcoholic fatty liver. So you called NASH, or some people call it NAFLD, which is non-alcoholic fatty liver disease. And this is a lifestyle problem, usually. So it's usually related to the diet that we eat and us becoming obese or overweight. And it starts off with fat deposition within the liver when it's called a fatty liver. It's not the hepatitis component, the H component is not there. As the amount of fat increases, you get an inflammation. In some patients, you will get an inflammation, and the inflammation leads on to scarring, and ultimately you get cirrhosis. But NASH differs from other causes, from many other causes of liver disease, in that even if you don't have cirrhosis, with NASH itself, you can go on to develop tumors of the liver. Then hepatitis B and hepatitis C, very common, not so common, I mean, less common now, but it used to be a very, very common infection around this country. It still is, but what's changed is that fortunately there is now good treatment for hepatitis B and hepatitis C, and there's also a vaccine against hepatitis B. So as a result, the number of patients that we're seeing compared to how many we used to see maybe 15, 20 years ago has considerably reduced. And then there are some rare metabolic diseases in children. One of them, I mean, it's not important to know which ones, but some of them, like tyrosinemia, glycogen storage diseases and others, can also predispose to developing this cancer. The other things which contribute are males are more, susceptible to developing these cancers. Alcohol and tobacco use, obesity, I mentioned. Diabetes also, long-standing diabetes can contribute to non-alcoholic steatohepatitis. So it may give rise ultimately in some patients to tumors in their liver. And then there are certain toxins, not so common here, but in places like sub-Saharan Africa and all, they get aflatoxin and some old radiological contrast agents which are no longer used. They could contribute to developing these tumors. So that's HCC. Now, intrahepatic cholangiocarcinoma, I'm going to, as I mentioned, I'm going to talk about it together, since it also presents in a very similar way with a single, mostly a single tumor inside the liver and a background liver disease. So here again, many of the background causes are the same, like cirrhosis, NASH, hepatitis B and C, but there are certain specific illnesses. There's one called primary sclerosing cholangitis, which are also called PSC, which is a disease of the bile ducts, which predisposes to developing this tumor. In India, we don't, most of the cholangiocellular carcinoma we see is de novo. That means it happens without any background liver disease. But if you have this primary sclerosing cholangitis, you're at a considerably higher risk of developing this tumor. Similarly, there are other biliary diseases like choledochal cysts, which is basically that instead of having a biliary, we call it the biliary tree. So it looks like the trunk of the tree is the main bile duct, and then all the branches inside the liver. Here, what you have, you develop cystic dilatations of the bile duct, either inside or outside the liver. And this, if it's not detected in adults, about 20% of adults who develop this are going to go on to developing cholangiocarcinoma. Stones, primary stone formation within the liver. I'm not talking about gallstone disease. I'm talking about a liver which produces stones. So it's a defect in the biliary bile that is being produced tends to be lithogenic, and they tend to develop stones. And in the Far East, there are certain parasites like liver flukes, which can get into the biliary system and cause a chronic inflammation of the biliary system and ultimately carcinoma. And the other ones which I've mentioned, like male gender, alcohol, etc., are common between the two. So essentially, you have HCC with underlying liver disease and CCC with underlying liver disease, and also certain biliary diseases which predispose to developing the cancer. So how can you prevent it? For HCC, it's been well established that if you've got a patient who is at risk for HCC, and who do we count as at risk? Essentially, you're looking at patients with who have already been diagnosed with cirrhosis for any reason, or patients who have got hepatitis B or C infection. These are the two most common reasons. We would do a 6-monthly ultrasound and a serum AFP test. AFP is a tumor marker which is produced by the tumor, and if its level rises, then that is indicative of an that you may be dealing with a tumor. So this is what is recommended. But I must say, what ends up happening is that since many of these patients are diagnosed with cirrhosis in their maybe sort of early 50s or mid 50s, and you tell them to undergo screening, they'll do it religiously for 2 or 3 years, and then they get fed up of doing it because it keeps coming back normal, and then they stop, and then 5 or 6 years later they'll come back with a massive big tumor in their liver. But it's really important to do the screening, because a screen detected cancer is usually less than 5 centimeters in diameter and can be cured. Effectively, it can be cured by one or other means. Whereas a cancer which is detected only when symptoms develop, it usually means that the cancer is really advanced, and we're either unable to cure it, or the treatment is really prolonged and expensive and difficult. So it's well worth doing the screening. If money is not an issue, there may be a role, instead of doing 6-monthly ultrasounds, to do an annual limited MRI scan. And by that, I mean just limiting it to the liver itself and not the rest of the body. It doesn't require contrast. There's no radiation. And the pickup rate is better than with ultrasound. So that's for HCC. There is no recommended screening test for any of the other background liver diseases. So, for example, if you've got fatty liver, and you haven't developed cirrhosis, although we know that you're at an increased risk of developing a cancer, in fact, nobody has found screening so far to be particularly useful. And you don't pick up these tumors because the incidence is not high enough. And so it's generally not recommended at this point to screen, but I suspect that will change in the next few years. And similarly for cholangiocarcinoma, if it's somebody is known to have primary sclerosing cholangitis, then again, you could do an MRI and another tumor marker called CA19-9. But again, the pickup rate is not great and nobody's quite sure as to how often you need to do the screening. So generally, people say do it once a year, but
Madam Patel,
it's not an
in
ideal
Sheffield,
method of picking up these tumors. Also, you can treat the underlying disease. So there's vaccination against hepatitis B. And just a reminder that if anybody has got hepatitis B, then you need to check their relatives as well, because people who are living with them are at risk of developing it, contracting it from them. If the patient is established with a hepatitis B or C infection, then nowadays there's excellent treatment. And it's well worth making sure that they get treated, because that significantly reduces the risk of developing cancer and of developing cirrhosis. And even patients who have established cirrhosis with hepatitis B and C infection, if you treat them, their liver function improves and they may be able to, it reduces the risk of both cancer as well as the need for transplant. And if you are diagnosed with things like intrahepatic stones or with choledochal cysts, then surgery is recommended to treat these conditions so that you may be able to reduce the risk of developing cancer. The other things I'm sure are pretty much the same as you hear in other cancers. Avoid alcohol or reduce your alcohol intake. Try to stop it. Avoid smoking. IV drug use, especially for hepatitis C, because that's a big risk factor for hepatitis C. Try and keep your weight down. Avoid high-risk sexual behavior. Use protection so that your risk of developing hepatitis B or C as a sexually transmitted disease is less. Just one word about extrahepatic biliary cancers. The risk factors are pretty much the same. Remember, the extrahepatic biliary cancers are cholangiocarcinomas. The risk factors are the same, pretty much the same as intrahepatic cholangiocarcinoma. But the difference is that these patients tend to be diagnosed at a much earlier stage because they present with jaundice. The tumor size may be very small, but because they occur at the point where the bile duct has already formed and is coming into the intestine, even when they're the size of a pea, they will block the bile duct and produce jaundice. And it only depends on which part of the bile duct has been involved. When they're inside the liver, then they will involve one or other side. It's unusual for them to involve both sides, the bile ducts on both sides. So these patients most often, the intrahepatic cancers don't have jaundice, whereas the extrahepatic cancers will. And if I just go back to this slide, you'll be able to see why. If I have a tumor here, this side of the bile duct is draining, so there's no jaundice. If I have a tumor here, this bile duct is draining, so there's no jaundice. But if I have a tumor anywhere along this path, it's going to block the whole bile duct, and bile can't drain, and therefore the patient develops jaundice. So I think this is what I wanted to say about biliary, about the liver and biliary cancer. So if there are any questions on this, I'll take this first and then go on to discuss gallbladder later.
Okay. Well, I hope I'm able to digest a few now. Anyway, my first question is that, you said control being overweight, fatty liver. So even the lean persons have fatty liver. that
Yes.
way. So what is it only in that case, and it's a non-oncologic I'm talking about. So is it mainly the lifestyle factor which is responsible for the fatty liver?
So if you look at it, the vast majority of patients who have fatty liver are overweight. There are what you call lean NASH, or where you get people with normal body weights having fatty liver. So it doesn't mean that you're immune, but that's the same with any cancer. You can have, you so often say, oh, I'm a vegetarian. I haven't touched a drop of alcohol in my life. I've never smoked. I've been a good boy. I've never played around with women and all the rest of it. And why did I develop this? I'm a vegetarian, but I developed cancer. So it's much the same. There are multiple factors here which can give you a fatty liver, but the single greatest of them all is being overweight or having high cholesterol and high triglycerides. So
Okay.
if you lose weight and you manage your cholesterol and lipids with either diet, or more often you'll require some medication as you get older, a statin or something like that, then you will be able to control a lot of the fatty liver. And now this is an area where there is a huge amount of research going on, and there are almost every few months there are new medications which are coming out to try and treat it, because until now really all you could sell patients was it's a lifestyle disease, you need to change your lifestyle, and that's the most difficult thing to change. What everybody wants is a pill that's going to make it go away, but they want to continue. And when I say they, I'm talking about me as well. They don't want to exercise, and they'd love to have McDonald's every day and, lots of sweets and so on. So you've got to deal with whatever you can, try and treat whatever you can. But you're right, there are some skinny people who will have a fatty liver. Many of them are diabetics. So diabetes is a risk factor, but even without, you can get a fatty liver in some patients.
Right.
It's just bad luck. Yeah.
Now, in the case of, the secondary liver cancer, where the site is not the primary. So you said there are number of tumors all over the liver. So you definitely, I think in that case, surgery is not the option. So is it basically the chemo?
So surgery remains an option in some of them, and that I mentioned the colon and rectum in particular, and some of the breast cancers are amenable to surgical resection. But you're right that surgery on its own is not going to be enough to cure. Most often it will require some form of chemotherapy along with it. But about 20% of 20 to 25%, and in some studies have shown up to about 40% of patients with secondary liver cancer, which has spread there from the colon or the rectum, then those patients, somewhere between 20 and 40% of them can be permanently cured. So it's worthwhile chasing, if you've got a colon or rectum metastasis to the liver, it's worthwhile being very, very aggressive with such in the treatment of such patients. And surgery plays a very important role. Unfortunately, these patients often go to the oncologists, and they just get given a whole lot of chemotherapy for months and years. And the chemotherapy then damages the background liver and makes any form of surgery that much more risky. So in an ideal situation, such patients should be managed in a tumor board where there is both a surgeon, a liver surgeon, as well as a medical oncologist available, so that their further treatment can be managed together. Both the surgeon and the oncologist, medical oncologist, decide what is best for the patient together.
Okay.
I have a question.
Now, in the case of women, the estrogen hormone is responsible for, to some extent, for liver cancer. So is there any such a male hormone for males which can,
I don't think so. I mean, even the estrogen for liver cancer is not a big,
okay,
very important thing.
risk factor?
Yeah, risk factor.
Okay. So what type of
Sorry?
what type of diet after the liver cancer treatment one should have? Is it non-fatty food or something?
So, contrary, you think I've got fatty liver, so I should cut down on fats. Actually, the biggest contributor to fatty liver is carbohydrate. So, sweets, carbonated drinks, particularly South Indian diet is, you have this much rice piled on your plate and then you have a tiddly bit of vegetable on the side. It has to be the other way around. Just a little bit of rice, cut down on the rice, ideally not more than what fits into your palm. And the rest of your meal should be with vegetables or, if you're a non-vegetarian, whatever else you want. So cut down on the carbohydrates, increase the proteins. It's very easy to do in a non-vegetarian diet, more difficult to do in a vegetarian diet to make sure that you're getting enough proteins. Especially if they don't eat eggs either, then your options are limited largely to sort of dal, soya, paneer. There's not all that much. So many of the patients who come and say that, I'm a pure vegetarian and they feel very virtuous. Actually, for the liver, it may not be as good as one.
Choice.
Yeah.
Okay, now HPV vaccination for HPV,
Yeah.
you vaccinate a child at a very young
Yeah.
age, an infant rather.
Yeah.
But if one doesn't know,
Yeah.
say at my age, I don't know whether I was vaccinated at that time or not. So up to what age one can have HPV
You can
vaccination?
have it at any time, any age.
Even if you had taken it earlier at a younger age?
So if you want, the ideal thing is you can measure in your blood whether you have antibodies against hepatitis B.
Okay.
So you may have heard of HBsAg. Have you heard of HBsAg? That's hepatitis B surface antigen. So it's HBsAg. If you're HBsAg positive, that means you've got hepatitis B infection, a chronic hepatitis B infection. But you can actually measure the antibody to hepatitis B. So anti-HBs. Anyway, you can measure the antibody to the hepatitis B in the blood. We don't have to go into the details. And if you have a certain level, then if you have a certain level, the level is more than 10, if you have a value more than 10 of the antibody, then you are immunized against hepatitis B. And if you have a value less than that, or you don't have any antibodies, then you should get immunized.
But normally it's a single dose vaccination?
3 doses. 3 doses. Yeah.
Okay. So you being a liver transplant expert, may we know if after removal of the liver tumor, you have done a liver transplant of such a patient?
Yes, it's called a salvage transplant. It's not uncommon. So sometimes you resect the tumor, and then there are 2 situations in which you might do a transplant after that. Most of the time, a patient comes to you with a cancer, and if it fits within certain criteria, you can do a transplant directly. But supposing you felt that you could resect this tumor, and then there are 2 situations in which you would do a transplant later. One is if the biopsy comes back as showing that it's a very aggressive tumor, then you know that it's going to come back after your resection. You could offer the patient a transplant. And the second is that it may not be all that aggressive, but if the tumor comes back, if it recurs within the remnant liver, then you could offer the patient a transplant at that point. Both of these are called salvage transplants.
My last question on the liver cancer, there are very stringent laws for liver donation. If there is no possibility of getting a donor within the family, the procedure of getting permission for an outside donor is so cumbersome and lengthy that the patient may lose life. What do you have to say in that,
So in South India,
Mhm.
there is a lot of cadaver. I won't say a lot, but there is a reasonable amount of cadaver donation. It's a tiny minority compared to what is available abroad. Like if you see abroad, many of the countries, there are about 30 cadaveric organ donors per million population. In India, we're at about 1 per million population. So it's very low, but still, at least there is the potential for cadaveric organ donation. And if you see in our own work that we do here, roughly 40 to 50% of the patients we do are cadaveric donors. The rest are live donors. Like in Delhi, almost no cadaver donors. It's all live donors. So there is a culture of organ donation down south. And so it is available, and that's not difficult, but you're right, you have to wait on a waiting list. And if you're too sick to wait for 6 months or a year to get an organ, then you will die on the waiting list. Now, the law does allow unrelated organ donors, but it's very difficult you can't go to the bus stand and say that, will somebody donate an organ, but I'm willing to pay so much. What the law means by unrelated donor is that if you're not a first degree relative and you're a distant relative, then you are permitted to donate. So you could have, I don't know, let's say a third cousin or something like that come and donate for you if you needed a transplant. But it's much more difficult to get legal clearance, because when you have a distant relative or what the law considers an unrelated donor, then the onus is on the family to prove that this person is not being taken advantage of or is not being paid for the organ donation. Whereas when it's a close relative, the law assumes that the person is donating out of the goodness of their heart. And so it's a lot easier to get clearance. They don't feel that they're being paid or bought or being taken advantage of. So it's a lot more stringent process. It's not ideal, but that's what we've got to deal with.
And within how much time duration from a dead
That
person, from a dead
from
person?
The dead person? From the dead person, once you take the organ out from the dead person, I'm talking about brain death. I'm not talking about cardiac death. So brain death, once you take the organ out, you have about, theoretically you have 12 hours, but we're not, once you get beyond about 6 to 8 hours, you're beginning to worry that it's not going to function well. So you want to put it in as quickly as you can. So we rarely have to wait more than about 6 hours. It's very uncommon.
Thank you.
Can I ask a question?
Yes, ma'am.
Put it in the box. Can a part of the liver be operated upon and taken away, or the whole liver has to be taken off?
No, a part of the liver. So if you've got a normal, healthy background liver, you can actually lose up to about 75 to 80% of your liver, and you'll be fine. You can survive on 20-25%, and that will grow back. But if you've got background liver disease like cirrhosis, then the selection process is much more stringent and much more, you need a lot more liver and the risks are a little higher. So in a patient with jaundice or cirrhosis or a fatty liver, we would want to make sure that they have about 40 to 50% of their livers remaining. And you can remove the rest. Yeah. So you can remove it. That's the most common. Yeah.
So now you will take biliary and I'll ask questions later.
Yeah, sure.
Okay, sure.
And if it's going too long, you please tell me. If anybody's getting fed up, then I'll shit.
Thank you.
So I'll just talk about gallbladder cancer next. This is a big problem in our country, especially in North India. And when we were students, medical students, they used to tell us about South America and Peru about being the #1 place in the world for gallbladder cancer. But nowadays, the #1 place in the world for gallbladder cancer is Eastern UP. It's extremely common in these parts, and no one is absolutely certain why. But one of the things which is, it's believed that it is related to pollution, particularly water pollution. And there are a number of studies which have shown that proximity to the Ganges or the tributaries of the Ganges is a risk factor for developing gallbladder cancer. We don't see it as much in South India, but we do see it. It is extremely common up north, and most GI surgeons or oncologists, the #1 operation that for cancer that they are doing is for gallbladder cancer. So it is a big problem. The second issue about gallbladder cancer is it's a really nasty cancer. So the majority, only maybe 10 to 20% of patients can be operated on at all by the time when they're diagnosed. And most of them recur even after surgery and chemotherapy. So you may be able to prolong their life and improve their quality of life with surgery. But the vast majority of these patients don't survive, even with treatment, more than a couple of years. And most of us who've treated these patients, we have a handful of patients over our entire careers who have survived for 5 years, 6 years after gallbladder cancer. So it's a really, really nasty one. So what are the risk factors? Gallstones. About 70 to 80% of all patients with gallbladder cancer have got gallstones. And no one is, it's obviously gallstones are extremely common in the population. So it doesn't mean that everybody who gets a gallstone is going to get gallbladder cancer, or who has a gallstone gets gallbladder cancer. In fact, it is only a very tiny minority of all the patients who have gallstones who may develop gallbladder cancers. And actually, that is the reason why we don't recommend surgery for everybody who has gallstones, because if you operated on everybody for gallstones, the risks of surgery or the complications of surgery are higher than the risk of one developing gallbladder cancer. So we're very, very, it's still not a recommendation that just because you're in a high-risk area, that you must have your gallbladder removed. But certainly, if you are in a high-risk area like North India, particularly Northeastern India, we would recommend removal of the gallbladder if you have a relative who has had gallbladder cancer and you develop gallstones. Even if obviously if they're symptomatic and they're causing you pain and all that, then you have to have it removed. But that's not for risk of cancer. I'm talking about patients who have got no symptoms and by an incidental pickup of gallstones on an ultrasound. So if they have a relative, a close relative who has gallstones, or if ultrasound shows that they have thickening of the gallbladder wall on the ultrasound. Of course, this may be because of inflammation, but because they're living in very high risk areas, then these patients are also often recommended surgery. It's very difficult to, if a patient comes and says, I'm worried about, in those areas, comes to say that I'm very worried about developing cancer, it's very difficult to tell them that, no, don't worry about it, leave it alone. So, you need to discuss this with the patient. But if you look scientifically, purely on the basis of science, the recommendation is to operate on gallstones only if the patient has pain and not for fear of developing gallbladder cancer. But in high-risk areas, you have to modify that decision after discussion with the patient. The second is porcelain gallbladder. Porcelain gallbladder is a very it's a nice name, but what it means is that the gallbladder has become calcified. And so it on a plain X-ray, it looks white because it looks like bone. And you can see the whole gallbladder with the shape of the gallbladder outlined in the calcification that's happened in its wall. Porcelain gallbladder is reported to have a risk of gallbladder cancer of in 1 in 5 patients. So if you see a porcelain gallbladder or you're diagnosed to have a porcelain gallbladder, definitely you'd be recommended a cholecystectomy. Primary sclerosing cholangitis, which we talked about earlier, is also a risk factor. But again, most of the time, these patients would not be operated on unless we did some screening with the MRI CA19-9, like I told you earlier, and that may warrant a cholecystectomy. Abnormal junction of the ducts of the pancreas and bile duct. I'll just go back to this picture. You can see this has actually not been shown properly. This bile duct and the pancreatic duct normally join at a very acute angle. So instead of joining here, it comes and joins here like this. It starts curving forward from here. Sorry. So that is the normal pancreaticobiliary junction. But some people have an abnormal pancreaticobiliary junction. And in fact, this picture would qualify as what a typical abnormal pancreaticobiliary junction looks like, where the bile duct joins the pancreatic duct at a right angle. And these patients are at risk of developing gallbladder cancer. And this is particularly not so common in our country, but another area which is high risk for gallbladder cancer is Japan and Eastern China. And in those parts, the abnormal pancreaticobiliary junction is a risk factor. Gallbladder polyps, again, these are different from gallstones. Gallstones are stones which move around inside the cavity of the gallbladder. Gallbladder polyps are little bumps of the lining of the gallbladder. So they're attached to the wall of the gallbladder. Many of these, in fact, most of these start off as benign. And it's only if they reach approximately 1 centimeter in diameter that one recommends that these are removed, because that's when the risk of cancer developing in them increases. So these patients need to be kept on follow-up with follow-up ultrasounds. And if the polyp is growing in size, then a cholecystectomy is recommended. So ethnicity, I mentioned that, if you come from northeastern India, or you're from Peru and certain other parts of the world, you're at high risk. And there is a hereditary component, but it's not been properly defined. So people with close relatives who have developed gallbladder cancer and who have gallstones, they do, there's a low threshold for removing their gallbladder. Again, as with anything, if you're fat, you smoke, you drink, and unfortunately, if you have diabetes, you're at risk for developing this tumor. But this is a really nasty one. And if you're, but these are the risk factors, and the prevention can only be by cholecystectomy if you identify a risk factor. So I take the questions on this and then move on to pancreas, which is the last one.
Okay. In the case of heart arteries, when they get blocked due to plaque and calcium deposits, so bile ducts also get blocked. But what is it just the tumor blocking the bile ducts, or there is some other?
These are two separate issues. In the arteries, it's plaque which is blocking. Bile duct getting blocked is due to a stone or a tumor or some injury to the bile duct. That's what gives rise to blockage of the bile duct. Are you talking about heart disease and biliary disease association?
No. I'm only asking the blockage is due to what?
Yeah. So the common thing is a stone.
Okay.
Next common is a tumor. Third common is if you've developed a narrowing of the bile duct because somebody did an operation and injured it. Yeah.
So there is a volunteer whose close relation is a patient of cholangiocarcinoma.
Right.
So they want to know the treatment options. She
Which
is
part? Where is
right
cholangiocarcinoma? Is it within the liver or outside?
outside the liver, I think.
Yeah.
Outside the liver.
So,
So is it he's right now on immunotherapy, but it doesn't seem to be helping him much. So is that the
so I would need to see the imaging.
okay?
But if surgery, if it is not metastatic and it's localized disease limited to the bile duct, then surgery is the number one treatment.
That has been done, I think.
And it's
But anyway, I'll
anyway, you can send me the details
sure,
later.
sure.
It's
Okay.
difficult to talk about a specific.
Okay. Sometimes bile accumulation in the body can become serious health problem after maybe gallbladder removal. Also, I know of someone. What is the? Will you explain that? What happens because bile?
That's not actually that's because of the pigment which causes bile to be green or yellow in color is called bilirubin. And that is what is produced in the liver and is excreted in the bile. So if there is a blockage to the bile duct from any reason, then the bilirubin is not able to get out into, go into the intestine. Bilirubin is also the thing which gives our stool its color. Okay. So when there is a blockage to the bile duct, the bilirubin backs up inside the blood and the patient develops jaundice. Typically, they have a very, very bright yellow or sort of greenish jaundice. It's the kind of jaundice you can make out from across the street. They're usually very, very deeply jaundiced. They usually have a lot of itching because these bile salts get deposited in the skin and they have a lot of itching associated with it. And their stools becomes pale or white in color because the bilirubin pigment is not reaching the intestine. So this is called obstructive jaundice. It's called that because the bile ducts are obstructed. And as I mentioned, the one which causes, although stones are the most common cause, the one which causes this typical triad of deep jaundice, itching, and pale stools is most commonly a tumor blocking the bile duct or an injury to the bile duct, which is causing a narrowing of the bile duct. So post-cholecystectomy, if somebody's developed jaundice, it's either because the bile duct has been injured during the cholecystectomy or because a stone slipped out, was missed from, or either slipped out of the gallbladder during
blocked it
and blocked the bile duct, or that gallbladder had a tumor in it which was not diagnosed or it was missed during the operation. Nobody thought about, didn't see the tumor, and the tumor has now recurred and blocked the bile duct. So if you get jaundice after a cholecystectomy, these are the three reasons why you might get it most commonly.
Dr. Sanjay, I see, a lot of gallbladder people who have been operated and the gallbladder has been taken out. They are complaining of, having some problem with the digestive system. Is it connected?
So the problem is that in many years ago, people said that any kind of dyspeptic symptoms were also caused by gallstones. So anybody who had dyspepsia went and had a gallbladder. It was an indication for advising them to have their gallbladder removed. Now we know that dyspepsia is not caused by gallstones. The typical symptom of gallstones is severe pain and fever and sometimes vomiting, sometimes jaundice. So that the reason why some of these patients have these dyspeptic symptoms is that either their diagnosis, their symptoms were attributed to the gallstones, wrongly attributed to the gallstones. So their symptoms are persistent after they've had the surgery. They had dyspeptic symptoms, went and had an ultrasound, was found to have gallstones. Somebody told them it'll get better after removing their gallbladder, but it didn't, and the symptom persisted. But the second is that you may have had your gallbladder removed for all the right reasons, but
Sound.
Sorry, you have been muted.
Muted.
so, but once you've done the cholecystectomy or any surgery, patients tend to attribute any new symptom they have to the surgery that they've received. It's quite common for somebody to come with, say, having had a hernia done, and then they say, ever since you did my hernia, I've been having headaches. It's got nothing to do with it, but patients may associate one symptom with their operation. And as I mentioned, in North India, very often the gallbladder is removed because of fear of developing gallbladder cancer if they're in a high-risk area. And so very often their gallbladder may not have been removed for the right reasons, in terms of the symptoms. And so their dyspepsia may persist. But there's no direct correlation between gallstones and dyspepsia.
Thank you.
Normally, I can see gallbladder polyps as one of the risk factors, all right, on the screen.
Yeah.
We generally mention that polyps are benign tumors.
Yes.
But in when in colonoscopy you find a polyp, and here also in gallbladder,
absolutely. If they're over a centimeter in size, whether they're in the intestine or whether in the gallbladder, these polyps have a risk of turning malignant.
That's why they do the biopsy, remove it, and
Dr. Dr. Sanjay, I just want to ask. Can I ask the question, please?
Yeah,
you are talking about the pollutants in the river in the eastern UP.
Yes.
So which pollutant is directly related?
I honestly, I don't know, ma'am. There are a huge number of, there's a lot of this information on the net, but because that's been one of the primary areas of study. But honestly, I'm not sure. I think it is a lot to do with the certain chemicals and there are some heavy metals, but I don't know the details. It's not one single thing. It's multiple pollutants which have been attributed, which have been, which are culprits. But I honestly don't know the names off the top of my head. No.
My last question on which is common to both biliary and pancreatic, you get at the last stage lot of irritation, kharash hoti hai bahut zyada in these two cancers. So what is the reason? Is it jaundice to hai develop ho jata hai, but
I didn't. What is the symptom that you're talking about?
Skin irritation.
Irritation. That's why I told you the itching. Itching happens because of the jaundice.
Okay.
The bilirubin, the bile salts, because they cannot enter the intestine and be passed out, they regurgitate into the bloodstream and then they get deposited in the skin. And those bile salts cause severe irritation. And actually, if you relieve the jaundice, that means if you put a stent inside the bile duct and open up the bile duct so that the jaundice is relieved, the itching disappears within 24 hours or just a few hours. The first thing patients notice when they wake up after having had a stent placed in their bile duct is my itching is gone. The jaundice may take a few weeks to go, but the itching goes almost immediately.
Right. On to you now for the next cancer.
Okay. So this is the last one. Sorry. Oh, yeah. So again, pancreatic cancer is a very common cancer, both in our country as well as abroad. And again, it's a very lethal cancer. Only about 20% of patients are diagnosed at a time when they can still be operated. And so, if you imagine the pancreas as being like a fish with the head, body, and tail, The tumors which arise in the head, they are adjacent to the bile duct. So one of the early symptoms they produce is jaundice. So it at least gets diagnosed fairly soon, well, with, not too advanced. But tumors which are in the body and tail are away from the bile duct. And by the time they get diagnosed, they're usually very large and have very often already spread. So what are the risk factors for, but the treatment of pancreatic cancer is whenever possible surgery first, or traditionally has been surgery first. There's a lot of work going on about giving chemotherapy prior to surgery nowadays. So many centers are using what neoadjuvant chemotherapy, giving chemotherapy first, then doing surgery, and then giving further chemotherapy. But it's surgery and chemotherapy are essentially the treatments. So what are the risk factors? In our country, one of the big risk factors is chronic pancreatitis. And this is a disease much like cirrhosis, but it affects the pancreas in the sense that instead of the scarring occurring in the liver, there is severe scarring within the pancreas and progressive damage to the pancreas. Alcohol is one of the prime causes for chronic pancreatitis, but another very common cause, almost equal to alcohol in our country, is some genetic disorder which gives rise to chronic pancreatitis. And there is this gene which has been, which I've mentioned, the PRSS1, which can be tested for in patients with chronic pancreatitis. And such patients, if it is there, they have a much higher risk of developing chronic pancreatitis. Chronic pancreatitis patients usually, especially the non-alcohol related chronic pancreatitis, they have a very high risk of developing cancer. And many of these patients will develop their cancer by the time they're in their 40s. So quite young when they develop. It also is picked up late because it's difficult to delineate the cancer in patients with chronic pancreatitis sometimes. It's a difficult situation. There are certain diseases which, again, unfortunately for pancreatic cancer risk factors, it's all very technical, but there are diseases in the pancreas called IPMN, which is intraductal papillary mucinous neoplasm, or you have MCN, which is mucinous cystic neoplasm, or PAN-IN, which is pancreatic intraepithelial neoplasia. Anyway, if you have some of these background diseases, which are low-grade tumors of some kind or the other, these patients can also go on to develop the regular pancreatic cancer. And then there are a lot of different cancer family syndromes and genetic abnormalities which also predispose you to developing pancreatic cancer. So the Peutz-Jeghers and polyposis coli, these are what we were talking about earlier, ma'am, with polyposis syndromes, patients with lots of polyps in the bowel, they are at higher risk of developing pancreatic cancer. There is a disease, this FAM, which I have never ever seen in my life, but it does predispose. And some of the hereditary non-polyposis colorectal cancer syndromes are also at risk for pancreatic cancer. There is an association between breast cancer and pancreatic cancer with the BRCA1 and BRCA2 genes. And patients who have close relatives who have got pancreatic cancer are at a higher risk of developing cancer themselves. The problem is nobody knows quite what to do about this, because if you diagnose these tumors, many of them will develop the tumor by the time even if you have this condition, pancreatic cancer is often diagnosed somewhere when they're in the region of about 50 to 70 years. And what do you remove? Which part of the pancreas do you remove in order to prevent the cancer? If you're going to, even if you're at a high risk for cancer, if you go and remove the whole of the pancreas, you're leaving the patient with a terrible quality of life. and the operation itself is not without substantial risk. So actually, there is a big debate as to whether these patients should be diagnosed. Should you go out and try to diagnose these patients and screen these patients, since there's not a lot you can do about them. And in the UK, at any rate, the national recommendation is that there's no point in doing screening. So unless a patient themselves comes forward and asks to be screened or wants advice about screening, but the recommendation is don't screen. Whereas in the US, they recommend that these patients be screened and aggressively followed with repeated CT scans and MRI scans. But even having done that, very often you pick up the tumor late and you're not able to help the patient all that much. And they just have a terribly anxious life because they're constantly going from one screening test to another. Here, diabetes is important in that there is an association between diabetes and pancreatic cancer, but it is not the common diabetic who develops pancreatic cancer. New onset diabetes has been associated with pancreatic cancer. So if you have a patient with new onset diabetes who's sort of middle-aged or in the older ages, no family history of diabetes, also associated with dyspeptic symptoms, you might want to do a scan to try and see if you can diagnose cancer in these patients. And the reason they develop diabetes is because the tumor, the pancreatic cancer itself, produces a substance which can make them diabetic. So if you treat the pancreatic cancer, the diabetes goes away. So obviously you can't be going and doing a CT scan on everybody who turns diabetic. But if there is a subset, like I mentioned, of patients who had been newly diagnosed, who don't have a family history, and they have some abdominal symptoms that you're not sure of, then it may be worth doing a scan to try and pick up this tumor. So that's really all I have to say about pancreatic cancer, and I'll answer whatever questions you have.
Whatever questions I had in mind, most of them you have already answered, like correlation between breast cancer and pancreatic cancer and all. But my one question is our pancreas removed under some conditions, and what complications are likely to come then?
So pancreas is removed, most common reason being for some form of cancer. So some of these pancreatic cancers are very diffuse and involve larger parts of the pancreas. So you do a total pancreatectomy. It is a very morbid operation. So patients develop two main problems. One is, of course, they develop diabetes if they're not already diabetic. But the type of diabetes you develop here is much more difficult to manage. Because the pancreas produces two hormones. It not only produces insulin to lower the blood sugar, it also produces glucagon to raise the blood sugar. And so it's like the two reins of a horse. It's sort of keeping a balance between these two enzymes. So when you have some part of the pancreas remaining, your pancreas continues to produce glucagon, which raises the blood sugar. So you never, any diabetic will tell you it's not the high blood sugar which kills you, it's the low blood sugar which can kill you very fast. High blood sugar, if you haven't managed your diabetes and you've left it alone for years, then you might have problems with high blood sugar. But it's low blood sugar which can kill you very quick. And who don't have any pancreas at all, they can have dramatic drops in their blood sugar, which can be life-threatening. So that's one issue. And the second is that the pancreas produces enzymes to help you digest your food. And those enzymes are now, of course, not being produced. So you don't digest your food, you get diarrhea because you're not, particularly with fatty food. But nowadays there is, you can get the pancreatic enzymes in capsule form. So patients can be managed. And if you really, really need to do a total pancreatectomy, nowadays we do them on selected patients, and we are able to handle the post-op complications.
Thank you very much. Thank you. I think we'll take the questions in the box maybe later because I'm not able to, note all of them. We'll send you the questions and then, we'll get the answers and pass it on to them.
Okay.
Thank you very much, Dr. Sanjay, for
Dr.
such an
Sanjay,
enlightening.
I have a question. Can I ask, please?
Please do.
Yeah. I read that in lung cancer, in some cases, in the chronic infections, a patient get jaundice, and when you test for that, you find that the cancer has started from the lung. How is that transferred to the liver?
I mean, lung cancer can spread to any part of the body, just like any other cancer. So
Okay.
if it spreads to the liver, then it depends. If the liver has been extensively replaced by lung cancer, or if the tumor has it has spread to the liver, but it is close to the bile ducts and blocking the bile ducts, then you could get jaundice with lung cancer. But otherwise, usually it's not a common association between lung cancer and jaundice. It does happen, but not commonly.
Okay.
Yeah.
And one of the liver cancer patient, he was quite lean, non-alcoholic, but he got liver cancer, but it was at the junction and he could not be, at the bile and the liver. So he could not even be, surgical operation was also not possible for the patient. So there are cases, but what could be the reasons? What other risk factors we were just trying to see?
I mean,
what could have happened?
I've mentioned the risk factors, but like I say, like patients will keep coming and saying that, I've been so good all my life and I've still got cancer. I've never drunk a drop of alcohol. So I tell them to start drinking now because anyway, they've, no, I'm just joking. I don't say that.
Yeah.
But, sometimes you can do everything right and then things still go wrong.
Yeah, Dr. Sanjay, I wanted to ask you about HIPEC treatment, hypothermia intraperitoneal chemotherapy. Is that recommended for all GI cancers?
Not all GI cancers. It's particularly for colorectal liver metastasis and, ovarian, which is not GI, but ovarian. And these are the two commonest, the ones that do the best with HIPEC.
Okay.
Yeah.
Is it very successful?
Ma'am, I don't do a lot of it because it's not my focus is all liver and pancreas and biliary.
Okay.
But I think in certain situations it is, and it also you have to define what you mean by success. We're talking about a pretty advanced cancer by the time it's spread to the peritoneum. So sometimes what doctors consider success, patients don't consider a success. So that is a conversation between the doctor and the patient.
Okay, thank you very much.
Yeah.
Thank you. Before I pass on the floor to Dr. Colonel Tomar, I would thank Mrs. Govil also for advising us that that you can contact Dr. Sanjay for GI cancers. Thank you, Jyotsna. And now I will, we look forward to the next session whenever you are free. There is no sort of this thing for the next 3 cancers in the GI track. And now may I request Colonel Tomar to propose the vote of thanks. Would you like to say something before that, Dr. Sanjay?
Me? No. Just thank you very much for this opportunity, and I enjoyed it thoroughly.
Just now you, Mrs. Govil?
No, I've been educated as much as everyone else today.
Thank you. Colonel Tomar, please.
Thank you, Aruna ma'am. Good evening, everyone. I am Colonel Ajay Tomar. I am the CEO of ICS Delhi branch. It was a wonderful session, and we all have learned something which we had not even heard of before. For that, I would like to, on behalf of the chairperson, Indian Cancer Society Delhi branch, I would like to thank Dr. Sanjay for such an educative session. It was, things which we have not heard of. We have much more armed with information now. And like also to thank Mrs. Aruna Umat for such a interactive and such keen questions, which Dr. Govil answered, because of which everyone is so much aware now. And I'm sure all of us on this meeting would have learned a lot. Thank you, everyone. Thank you so much.
Thank you.
Thank you. Thank you very much.